Assalamu alaikum. The long clinical consultation day. First scenario, Mrs. Hala, 48 years old, complaining of headache. Her blood pressure 180 over 100. Please take history and examine her, address her concerns.
Hello.
Hello?
Hello, my name is Esosa. I'm one of the doctors here today. Can I confirm that you are Mrs. Hala, 48 years old?
Yes, I am doctor.
Hello, nice to meet you.
Me too, doctor.
So, I'm here today to discuss some issues regarding your medical condition. I may also examine you just to get to the bottom of this. Is it okay? Can I go ahead?
Yes, doctor, okay.
Okay. I'm also going to be taking some notes during our discussion, but just be sure that it's confidential and you have my full attention. Is that all right?
Okay, doctor.
Okay, so I understand that you've been having some headaches. Can you tell me more about this?
Yes, doctor, from 5 days I have this headache. It is continuous, so not relieved by any painkiller. I don't know why I have this headache.
Oh, I'm really sorry to hear that. Are you having the headache right now?
No, doctor, I take, it is relieved, somewhat relieved.
Okay, so it's relieved. Okay, at any point, if the headache gets worse and you need something for the pain, just let me know so I can give you some, okay?
Okay, doctor, thank you.
So you told me from what you said, it started 5 days ago and it's been continuous. Can you tell me where exactly you're having this headache? What part of your head?
All over my head, doctor.
All over your head. And just 5 days ago, did it start all of a sudden or was it gradually?
I was have headache before, but for these 5 days, the headache become more severe.
I see. So you have headache usually, but it's become more severe 5 days ago. Is that correct?
Yes,
Okay. And
yes.
so for how long have you been having headache in general?
Maybe 1 year.
So you've been having headache for 1 year and now it's become worse. Okay. We'll talk about this particular headache that is worse, and then I will speak again about the one you've been having before. So for this headache, can you describe it? What does it feel like? Can you tell me?
It is dull aching. It's annoying headache.
Dull.
For 1 week, about 1 year, when this headache starts, they said it is due to my blood pressure, but I didn't take any medication.
Okay. So is this headache is the way this headache is different from how it was 1 year ago?
Yes, before 5 days, it is become severe. It's the same, but more severe.
Okay, so the same but more severe. Okay. Is there any particular time this headache is worse?
Notice all over the day, doctor.
It's all over the day. Okay. Is there anything that makes it worse?
No.
Okay. Anything making it better?
Yes, but some painkiller make it better, but not really.
And painkillers. Okay. Can you tell me from a scale of 1 being the least pain you've ever had to 10 being the worst pain you've ever had, can you score the pain you're feeling right now?
From 6 to 7.
Okay, well, okay. And okay, so from 6 to 7. Oh, I'm so sorry for your suffering. Just let me know if you need any painkillers.
Okay, doctor.
Okay. So apart from this, are you having any problems with your vision at the moment?
Vision, no, doctor.
Okay. Have you lost consciousness since this headache started?
No.
Any fits?
Any what?
Fits.
It's no.
Okay. Any weakness in your arms or legs?
No, doctor.
Any problems with the way you sense the sensation on your skin?
No.
Okay. And this 5 days, is it getting worse or getting better or just the same?
It is worse than before.
Worse than before. Okay. Okay. So do you have any increased body temperature?
No.
Have you noticed any weight changes?
No, doctor.
Okay. Any problems with your appetite?
It's the same, my appetite.
Okay. Any lumps or bumps in your body?
No, doctor.
Any sweating, unusual sweating at night?
No.
Okay. So do you have any medical condition I should be aware of?
No, I don't know any medical condition.
Okay. Do you have any high blood pressure, for instance?
Yes, before 1 year they told me my blood pressure is high, but I didn't take any medication since that time.
I see. Okay. And how has your blood pressure been since then?
I didn't measure, but when I measure it today, it was high.
It was high. Okay. Can you remember how high it was?
180 over 100.
I see. Okay. Okay. Apart from that, any other maybe high blood sugar,
No, doctor.
any history of migraines?
No.
Okay. All right then. And before this headache, just to confirm, did you hit your head anywhere or did you have any injury to your head?
No.
Okay. So are you on any medications at all?
No, doctor.
Okay. What about over-the-counter medication?
Just the painkiller when I need only.
Okay.
Not too much.
Can I just confirm what painkiller that is?
Paracetamol, usually.
Okay. And okay. Are you taking any herbal supplements or remedies?
No.
Do you have any allergies?
No, doctor.
Okay. I'm about to ask a personal question. Excuse me for this, but this may be important. Any chance you could be pregnant?
No.
How are your periods?
What?
Your periods, how are they? Are they regular?
It is irregular, no change.
Okay. Are you on any hormonal therapy?
No.
Are you on any contraceptive pills or anything like that?
No, doctor.
Okay. Do you have children?
Yes, I have 2 children.
Okay. And when was your last pregnancy? When was your last birth?
For 10 years.
14 years. Okay. I'm sorry to ask you, but have you had any miscarriages in the past?
No. No,
Okay.
doctor.
Okay. So do you have any condition that runs in the family that I should be aware of?
I don't know, but I can't remember any condition. All my family are good.
Okay. And so is there anybody in your family with maybe a similar condition as yours or
No, doctor. No.
high blood pressure?
No.
Okay.
Maybe at my father at the end of his life, his blood pressure was high.
Okay. So there was a time your father's blood pressure was high.
Mm.
Okay. Okay. Apart from that, any other person in your family?
No, or no problem.
Okay. And is his blood pressure controlled? Is he on medications?
For me, I don't take any medication, doctor.
Okay. Okay. I'm asking about your father. Any problems with the
My
blood?
father, he died.
Oh,
He has high blood pressure in his last
oh,
days.
I'm so sorry to hear that. What do you do for a living, please?
I'm a teacher, doctor.
Okay. And how has this affected your occupation?
It's affecting me too much.
Oh, I'm really sorry to hear that. I'll refer you to the occupational health and see if there's a way we can help with that. And what about your daily activities? How has this affected your daily activities?
Yes, doctor, I can't do anything while I have this headache.
Oh, I'm sorry to hear that. We'll speak to the occupational therapists. So who do you live with?
My children and my husband.
Okay. Do you smoke?
No, doctor.
Do you take alcohol?
No.
Do you drive?
No.
No. Okay. I'm just going to ask you some few more questions and then I will examine you.
Okay.
So this headache, do you notice that maybe when you leave the house, it's better, or when you're in a certain place, it's better?
The same.
The same. Have you changed houses recently?
No.
Okay. Any skin changes?
Yes, doctor, yes. I have. I noticed that my skin become not as before.
Okay. Can I have a look?
Yes, you will find tight skin.
Tight skin.
Mm.
Okay. All right. Any problems with the skin being tight? Any problems with opening your mouth? Have you noticed more?
Yes, doctor, you are right. Yes, I noticed it.
Okay, okay. Any problems with your breathing?
Yes, also, doctor, I have shortness of breath.
Oh, I'm
It
sorry.
started
Yeah.
for few months. Few months start feeling shortness of breath. Also.
Okay, okay. Sorry to hear that. Okay. Any cough?
Yes, I have cough.
Is it a dry cough or is it phlegm with the cough?
It's dry.
It's dry. Okay. Any tightness of the chest?
No, doctor.
Okay. Yes?
It's shortness of breath.
Okay. Any racing of your heart?
No,
Any chest pain?
no.
Any problems with swallowing?
Sometimes, doctor, yes.
Okay. Do you feel some heartburn?
Heart pain? No, no,
Heartburn?
no,
Okay. Any tummy pain?
no, doctor.
Okay. Um, I'm just going to examine you now, if you don't mind. So I'll first
Okay.
like to start with the observations, most especially the blood pressure, the vital.
Blood pressure
Yes.
180 over 100.
Okay. What about the other vitals? Are they okay?
Other vitals, okay. Yes.
Okay. I'm going to start with the hands. I would like to inspect the hands. I would like to check for this tightness of the hands.
Where in hands? Yes,
Yes.
it's skin tightness in hands.
Okay. And then looking at the tips, I want to look at the tips. I want to check for peripheral ring.
No, normal.
Okay. I also want to check the hands for telangiectasia.
No, no, not telangiectasia.
No telangiectasia. I want
Only tight skin.
only tight skin. Any whiteness on the hands for calcinosis?
No.
Okay. I'm also going to look at the face. Apart from the pallor, I want to see the face itself. Is it tight? Is the mouth tight?
Little tight.
Okay.
Just looks tight.
Okay. So I'm going to check the eyes for pallor, ask her to open her mouth and check her mouth as well. I'm also going to go to the chest. I'm going to listen to the
Yes.
chest, to the lungs.
Yes, you will find fine basal crepitations bilateral.
I'm going to ask her to cough and then check again.
Still present.
Okay. I'm going to listen to her. I'm going to check her apex beat.
Normal. Please.
Okay. I'm going to check for parasternal heave
Normal.
and loud P2.
No, normal.
I'm going to examine her abdomen. I'm checking for tenderness,
No tendons.
for hepatomegaly or organomegaly.
No organomegaly.
Okay. For
2
headache,
minutes left.
I'm going to do a fundoscopy. Any
No need.
what?
No need.
Okay, eye movements. I'm going to check for eye movements.
Eye movement, not much.
Okay. Thank you, Mrs. Hala. Can I know what your concerns are?
Doctor, why I have this headache and why my blood pressure is too high like this?
Yes, I appreciate your concern. From my examination and our discussion, I believe that you may be having a condition called systemic sclerosis, and that it has affected your kidneys, and that's what's making your blood pressure to be high. I know this is quite a lot to take in at the moment. Have you ever heard of this condition called systemic sclerosis?
No, I didn't hear about it.
Okay,
What's this?
okay. So it's when your body's mechanism, your defense mechanism is fight against your body and causes some damages. So this causes your skin to become hard, like you have shown me, the tightness of your skin around your mouth and in your fingers. But it can also affect other organs in your body. from the reason you're having the difficulty with breathing, which is from it has affected your lungs, and the headache because your blood pressure is high. And one of the reasons this blood pressure can be high is because it's also affected your kidneys.
Okay.
You understand what I'm saying?
Yes, doctor. Will you give me the medication?
At the moment, we'll have to admit you for more investigations and treatment because this is quite urgent.
Okay, doctor. Okay, thank you.
Do you have any other questions for me?
No.
Okay, so there will be a group of we're going to involve a group of specialists who will also come up with a management plan for you. If you have any further questions, please don't hesitate to ask me. Thank you.
Okay, time is up. Perfect.
Okay, doctor.
Well done, Dr. Isosa. Let's hear the examiner questions. Dr. Marwa, please.
Okay, present your case, please.
This is Mrs. Halle, 48-year-old lady who was presented with headache and elevated blood pressure. On examination, I found her to have a tight skin around in her fingers and around her mouth. In addition, she had some crepitations in her chest, which I suggest to be in her chest. And at the moment, I believe that she may be having, from this examination, I believe that she may be having systemic sclerosis, and the reason for her headache may be due to renal crisis, scleroderma crisis. In view of that, it is an emergency, and I would like to admit her and investigate. I would like to investigate with routine blood tests such as a full blood count, electrolyte urea and creatinine, electrolyte sedimentation rate, liver function test, a urinalysis to check for proteinuria. Specifically, I would like to check for autoimmune screen, most specifically out of SAA, SSA, and SSB to check for scleroderma. I'll also do a chest X-ray and ultimately a CT chest to rule out pulmonary fibrosis in her. I'll also do an echo to also rule out pulmonary hypertension as well. For management of this patient, it will be multidisciplinary with involvement of the rheumatologists, the renal team, the cardiologists as well, specialist nurses, and occupational therapists. It will be non-pharmacological, first of all, with patient education and counseling, and then pharmacological in the use of antihypertensives. The best for scleroderma crisis is angiotensin converting enzyme inhibitors, and we'll continue to monitor her.
How many types of scleroderma you know?
So there are two types. There's the limited scleroderma and the diffuse scleroderma. The limited scleroderma comes with the CREST syndrome, where it's just limited mostly to the hands, to face, more to the skin, whereas the diffuse also affects the internal organs.
How you you said localized
and diffuse.
Diffuse. How can you differentiate between them in examination?
On examination in limited, you see more of what we call the CREST syndrome, where the patient may have more of skin changes, calcinosis Raynaud's phenomenon, some sclerodactyly, and some telangiectasia. In diffuse, though, this patient, and then yes, in diffuse, this patient may come with more problems with the internal organs, such as pulmonary fibrosis.
What the complication of scleroderma?
So, like we have seen in this patient, complications could be scleroderma crisis, where the blood pressure becomes very high and can lead to complications. Another is because of the fact that they have problems with their esophageal mobility, they could have small bowel overgrowth, which leads to diarrhea.
What is a specific investigation for scleroderma?
So that is the SSA and SSB.
Is SCL 70.
Yes, sorry, yes.
Uh,
SSCL.
in, any specific antibodies to renal crisis?
Um, for renal crisis, I cannot recall at the moment.
Oh, anti-RNA polymerase 3.
Ah, okay. Thank you.
Thank you. I finished.
Okay, I will add some questions because still 1 minute remains.
Okay.
Okay.
Dr. Sos, you mentioned the antibodies.
Yeah.
Can you repeat them for specific for the diffuse and for the limited type?
I mentioned I mentioned SSA and SSB. For the thing they
The
also
name,
called, yeah, yes, I'm
I
trying to.
think this is abbreviation, right?
This is a yes. I think
Yeah.
there is a topoisomerase and
Okay. Yeah.
yes, SCL 70.
Scleroderma 70
Yeah, I think that's
for the for the diffuse,
diffuse.
and centromere for the limited, right?
Thank you.
Okay. You mentioned pulmonary hypertension. Which
Yeah,
type will be complicated with pulmonary hypertension?
I believe it's the limited. The limited would be
Yes.
yes.
Perfect.
Diffuse would be yeah.
Yeah. Okay. How clinically you differentiate between limited and diffuse? You mentioned.
Yes, for limited to more of skin changes using the crest syndrome, calcinosis on the hands, Raynaud's phenomenon on the fingers. Whereas the diffuse, because it's going to affect inner organs as well, you may see pulmonary fibrosis when you auscultate the chest.
What about the tightness? What level you can find in the hand?
I think for the limited, it will be worse. The tightness will be worse in limited.
Limited will be below the elbow,
Ah, okay,
and the diffuse will be above the elbow.
okay.
Okay, that's enough.
Thank you.
Well done. I will hear now Dr. Marwa comment, then I will.
I don't have comment, Dr. Asas did it only. And she take long time in first in the analysis of the complaint, and she catch the case from when she started to do the systemic review and asked about the skin change. She know the, the case.
Mm.
Okay, well, thank you, Dr. Marwa. I will comment on the performance. I think Dr. Sousa followed the approach, which I believe this is the best approach everyone can follow. Started by analysis of the complaint, onset course duration, what increase, what decrease, and the severity of the pain, the scale, the timing, everything she analyzed well. And she tried to know what is the most relevant system affected. She tried to roll out the alarming symptom. When she asked about fits, weakness, or pins and needles, just to roll out the alarming signs of headache. I think till this point, she was perfect related to the headache. But I want to pay attention to the headache related to the hypertension. So you
Okay.
have to know why this patient is having hypertension, not only headache. If you know the hypertension and the cause of hypertension, you will know the case. As Dr. Marwa said, when you ask about the systemic review and you start to analyze the systemic review questions, you found that this patient is having tightness in her skin. Uh,
Yes.
I'm not sure what specifically you ask about the skin to be mentioned by Dr. Marwa,
In
that
changing.
any skin change, right? You said like
Yes.
that.
Yes.
Perfect. So let's imagine you didn't ask this question. You will start analyzing the systemic review from the head down to the toe. But if you ask about the skin and already you discover that there is the skin change, so you will know the cause of the headache or the hypertension, and so you will have the cause of the headache. So back to the systemic review. I, I I believe you did also well when you ask about the constitutional symptoms, just to rule out any connective tissue disease or cancer or paraneoplastic, for example, or headache related to, for example, some space occupying lesion. Uh, you for the welfare you offer also the painkillers twice, which is good. Also, you ask here earlier if you have a headache, you cannot tolerate the headache, you can ask for painkiller. Later on, you ask when you found the headache or the pain scale more than 6 or 5, you offer again the painkiller, which is perfect because the patient mostly above the 5, he will not tolerate
Mhm.
the headache. Apart from that, you ask about the vision also to roll out something lead to increase interarterial pressure, which is also perfect in this scenario. Hypertensive encephalopathy, one of the important complication you have to roll out, and you ask about conscious level, which is also good. You roll out trauma and herbal remedies. You ask about allergy, but you didn't ask about recreational drugs.
Oh yeah.
And by the way, recreational drugs can cause cocaine, amphetamine can cause hypertension, and and so it can lead to the headache. So you can add just quick question about the recreational drugs. You ask about periods in this scenario, which
Yeah.
is I think a wrong question because I think this patient is already in menopause. I don't know, Dr. Marwa, give
She,
you
she's
regular.
48, so that's why she's perimenopausal.
Yeah, yeah. So supposed to be either pre or menopause. Anyway, miscarriage also is very important here. It might be related to the case, which is systemic sclerosis. It might be mixed connective tissue. If you found any joint change, I think in the systemic review, you miss the joint
Oh,
as well as the urinary symptoms or
yes.
urinary system. Suppose also it might be injured or it might be affected in this scenario because you have scleroderma renal crisis, you might have fluorescence in the urine. Please try to finish the systemic review questions
Mm.
after asking about the past medical history and surgical history. Before asking family history, I think this is the approach. It will guide you to the most important finding as well as the clue for the case, as in this scenario. Yes, family history is important. I didn't say don't or skip it. You have to ask family history. It might give you a clue, but you ask for the father hypertension. So, yeah, he's hypertensive, but what the importance to ask about his hypertension, either controlled or not?
Okay.
It wastes some time. So
Yeah.
better to ask if there is any condition, if there was any condition in the father, headache related to something serious or cancer on his head, to rule
Mm.
out any serious cause of headache
Yeah.
in the family, as well as the hypertension. Some conditions you might have family history of hypertension uncontrolled in young patients, like Liddle syndrome, for example, or cons with hypokalemia. But you will find the scenario going with cramps and hypokalemia, periodic paralysis, for example, or manifestation of hypokalemia, but not in this scenario. Here you are lucky when you discover there is skin tightness and you start to analyze the skin or rheumatological system questions. So you rolled in the involved system in this scenario, the skin, the chest, short of breath and cough, the difficult of swallowing, GI. You didn't ask about change of the bowel habit. So try to finish the system from the beginning. I mean every system. If you start to ask about the GI, ask all questions related to the GI. You ask about difficult swallowing, but you didn't ask about diarrhea, which is important. You mentioned them in the bacterial overgrowth syndrome when you start to answer the question for the examiner, but you didn't ask about it. What if this patient is having diarrhea? You'll be in
Mm.
trouble, right?
Yes.
Yeah, the examiner will maybe he will be shocking you when you ask. You will ask. He will ask you, "Did you ask about diarrhea? This patient was having diarrhea. What do you think the cause of diarrhea in this scenario?"
Mm.
So it will be related to bacterial overgrowth. But
Yes.
yeah, so you will be in trouble. You didn't ask about this question, and the patient might have this. Again, the genitourinary or urinary system you didn't ask, which is also here important, related to the frothiness in the urine. Family history, Travel history here is not important. Pregnancy, you ask, which also no need to ask about are you pregnant by any chance in this scenario, because I think it's difficult to be pregnant in this age. However, you have to ask about the kids. What do you think the relation between the last pregnancy, for example, or delivery in this scenario?
It could be what precipitated the crisis.
What? Again, sorry.
It could be what precipitated the crisis.
What condition might be related? I mean,
Uh,
name a condition.
Preeclampsia.
Okay, preeclampsia, but I guess it will be in the younger age, not in 48.
Mhm.
Anyway, you don't know if it is also in premenopause or menopause, so it's okay to ask. But what other cardiac condition might be involved related to the pregnancy? You have to rule
Peripheral
out.
cardiomyopathy.
Exactly, yes.
Yeah.
Yeah.
Mhm.
Okay, the examination, you start to examine the hand, the blood pressure, the vitals, but the pulse, the Raynaud's, you examine for the telangiectasia. I
Mm,
think you examine for telangiectasia.
yeah.
Sclerodactyly, you ask about.
Yeah.
Tight skin, the level of tight skin you have to do. You
Okay.
can, yeah, ask the patient to bench hair skin
Mm,
and go upward till above the elbow to know is it the limited type or diffuse type. The pulse is important here. What do you think the pulse importance in this scenario? You already mentioned
that.
the Raynaud's, the pulse related to the Raynaud phenomena, right?
Yes.
So this is secondary Raynaud. You might have secondary Raynaud in this scenario related to the systemic sclerosis. So you might have absent pulse.
Oh, okay.
So you have to offer examining the pulse.
Mm.
The skin already we mentioned, the proximal myopathy also you can examine. Do you think it's important here to ask about muscle myopathy?
Yeah. Okay. Yeah. Mm.
What the importance in this scenario? What do you think?
I think if you're thinking of if it's misconnective, she may have proximal myopathy from another autoimmune condition.
Yeah, so dermatomyositis or polymyositis, right?
Yes.
Because you have already the systemic sclerosis, you might have mixed connective tissue disease.
Yes.
Skin on sun exposed area for systemic sclerosis, sorry, systemic lupus erythematosus, right?
Yes. Mm. Yeah.
So it's complicated case, but it's classic case in the exam. The
Yes.
most important here to rule out the cause of hypertension, which is scleroderma renal crisis. Please don't forget to examine the renal areas for renal buoy,
Yeah.
right? Just to rule out renal artery stenosis.
Also,
Yeah, I think fair enough as a comment. Otherwise, you did well. Just advice, please don't offer the answers. She asked you one question, present your case, and you did everything in the answer. You mentioned the investigation, you mentioned the management plan, which is perfect. Yes, you did everything, but you didn't give a chance to the examiner to ask you what other questions. He might ask you different question, and you didn't give him the time to ask you.
okay. So,
You got it? Yeah.
I just present. I so I
Present your case.
present,
Yeah, this is
and then
a lady, 48 years, presented with headache. She found that she has hypertension earlier. She didn't take medication. At least give him differential or time to ask you about differential.
that's
You
true.
have category or skill in the exam performance. Differential diagnosis 4 marks. If you just enumerate the investigation, the management plan, what about the differential diagnosis? You didn't give him time to ask you about differential diagnosis. So I will ask you now the question. What do you think the differential diagnosis of this scenario?
Okay. So, differential diagnosis is scleroderma crisis. That's the first. The second is misconnective tissue disease.
Perfect.
Yeah. And then the third will be from the headache and high blood pressure. um, the hypertensive encephalopathy.
Perfect.
Yeah.
Yeah, so I at least give three differential.
Mm,
One of them, the case or the diagnosis, which is scleroderma renal crisis. The other one, yeah, as you mentioned, it might be related to mixed connective tissue disease. By the way, you can mention lupus nephritis as mixed connective tissue disease, right?
okay. Oh, okay.
Yeah. Otherwise,
Mm,
for this age and with a known cause, or if you roll out the all causes of hypertension, what do you think it might be the cause? What's called? If you start or you try to roll out all causes of secondary hypertension and you didn't find
any
what's called.
essential hypertension.
Perfect. Yeah. So you can simply mention this essential hypertension as a differential.
Mm,
Why? Because you don't know what the cause of hypertension in such age. It's
mm,
common to be essential hypertension, particularly if the father is having or was having hypertension.
sure.
So
Okay.
simply you can mention it.
Mm,
But in this scenario, it's straightforward as a case of scleroderma renal crisis. You
mm,
mentioned already the pharmacological therapy for this scenario, which is ACE inhibitor. Perfect. The
mm,
non-pharmacological, don't forget how to counsel the patient about the disease, the complication, the management plan.
mm, mm.
What's important here also in this scenario? What do you think as non-pharmacological?
Lifestyle modification. I think if she smokes, tell her to
Okay,
stop.
perfect. Yeah. What
Mm,
else? Something is important. Usually you start education the patient with hypertension with this.
and
Whenever you have patient with hypertension,
salt restriction. That
perfect,
help.
perfect. This, yeah. So it's restriction, dietitian also involvement in the team, just to regulate the diet, to have regime which is fitting the hypertension. It will be low salt, low protein, according to the scenario. Urine dipstick is important this scenario, and urine analysis, as you mentioned, to
Mhm.
rule out proteinuria.
Yeah.
Yeah.
Mm,
I
mm,
think if we have more than 1 hour to talk about the systemic sclerosis, the complication, the investigation, the examination, I'm trying to make it concise. So I'm trying as much as I can. But as you mentioned, also one of the important during examining the face is the buckling of the face. But don't mention buckling. So you can say narrow mouth opening and narrow also nostril.
mm.
How to do it? You can ask simply ask the patient to open her mouth widely. Don't put fingers, don't ask her to put fingers. So the best way is to ask her to open her mouth widely. Try
Mhm.
again widely, please, as much as you can. Then you can mention to the examiner it's narrow opening of her mouth
Okay.
without putting fingers because it's against the welfare to put or to ask her to put finger or to put your finger inside her mouth. It's against the welfare. So the best way to do to ask the patient to open her mouth widely and just to show the examiner that it cannot or it is having or she's having narrow opening. Okay.
Thank you.
Thank you too. You did it perfect.
Thank you.
Again, yeah, try to make the systemic review before the family history and to make to ask the question which make sense for the examiner. So avoid the question related to, for example, period in such age. Remember always whenever you have patient 45 and above, usually they don't have periods. So what you can ask either to ask about her periods before. What about your periods before? Because she might say to you, Doctor, I don't have periods. So it will show the examiner that you are not taking care of the age. You just ask questions without thinking about the age and the question related to the age.
Okay.
Yeah. Make sense for you?
Yes. Thank you.
Yes. Okay. Thank you too.
Because systemic sclerosis is a good case. Thank you so much, Dr.
Yeah,
Mal.
it comes regularly and frequently in the exam, by the way. You have to be ready how to manage, how to investigate, specific investigations, specific antibodies. Don't forget to mention mixed connective tissue disease
Mm,
investigation, which is anti-RNB. ribonucleotide antibodies. It's very important to ask about this because you might have mixed disease, not only systemic sclerosis. Yes, it will be
Mm.
presented with hypertension, but you might have discovered the other association, which possibly might be systemic lupus erythematosus or dermatomyositis, rheumatoid arthritis, Raynaud's, polymyositis. All of them are important to roll out in every question.
Yes.
Okay, antiphospholipid antibody, don't forget. You asked already about the miscarriage. You might have it as association.
Okay.
Okay,
Yes.
I
Eh,
think I'm done with the comment. If you have any question or suggestion, you can add. Any question, Dr. Isosa?
Oh, no, thank you. I'm clear.
Yeah, okay. Dr. Marwa, any missed point by me in this scenario? The
No,
differential?
no, you all covered. Oh,
Okay, so the differential you prepare is as the differential
as you
are,
said,
yeah, okay. Okay, Dr. Marwa, thank you. So if no suggestion from others, we can move to the next scenario.
Oh, send
Yeah,
it.
can you type the scenario for here? Yes, please.
Yes, send it now.
Okay, I will read the comment till you write the scenario. Doctor, no name, he mentioned pulmonary hypertension with the diffuse. No, pulmonary hypertension with the limited one, and the diffuse will have interstitial lung disease. Remember, internal organs, as Dr. Sosa said, internal organs will be associated with the diffuse type. So the internal organs consider the lungs as one of the internal organs. This is how I remember also.
Mm-hmm.
But the limited one, so you will have no organ, no internal organs, but you have some of the vessels affected, which is pulmonary vessels. So you will have, or you might have pulmonary hypertension. This is the way how to remember. So internal organs mean the lungs and the kidneys, for example. So you can remember that diffuse type will have interstitial lung disease, but the limited one will have pulmonary hypertension. Dr. Sausan said, yeah, Dr. Sausan Abdulaziz, very excellent. She did, yes, I agree. Impressive time management, exactly. Salt review. I agree. This is the best and the first advice for any patient having hypertension or borderline blood pressure reading. By the way, the exercise as well can control the hypertension initially, which is called lifestyle modification. You can start managing hypertension patient with lifestyle modification. But in this scenario, you have to treat the underlying cause. Okay. Thank you, Dr. Isosa. The scenario. You are the doctor in the general medicine clinic. Mr. Alfred Lee, 50 years old, has been referred to you with a 12-month history of diplopia. Kindly take a history, examine him, and address his concern. Dr. Marwa, I will give you 2 minutes. Write your approach. Be ready to start when you are ready. Okay, back to the investigation. Dr. Isosa mentioned them all together. I prefer again to start with general, specific, bedside, and image. Last will be invasive test. So let's remember every category, Dr. Isosa. If I ask you what general investigation you can do for this lady, systemic
So,
sclerosis.
O blood count,
Perfect.
U and E, um,
Perfect.
ESR,
Perfect.
liver function test, urine dip, urinalysis,
No, but keep the urine dip now because it
uh,
would be bedside test.
bedside. Okay.
Perfect. So this is these are the general or workup. Okay. The specific investigation, you mentioned already the antibodies, but don't forget which is the common antibodies important to mention, and it's not specific. It's sensitive one, but it's not specific in
Okay.
any.
Anna.
Exactly, yes. Antinuclear antibody. You have to mention Anna for any patient with having the autoimmune antibodies or autoimmune disease.
Okay.
Okay. You
Yes.
can add also what else specific. Don't give me for systemic sclerosis. Now you have systemic sclerosis patient, but you don't have what other association. So what other specific antibodies you can add?
Maybe anti-double stranded
Perfect. Yes.
before that. To rule out antiphospholipid syndrome, need
Perfect.
anti,
Antibodies for antiphospholipid. What else?
um and so antidro. If I'm thinking of polymyositis,
Jogren.
yeah. Jogren.
Yeah. Perfect.
Yeah.
Perfect. One more for rheumatoid.
Anti-CCP,
And rheumatoid anti. Yeah.
rheumatoid.
Rheumatoid factor. Yes. Anti-CCP and rheumatoid factor.
Okay.
And the specific investigation for systemic sclerosis, as you mentioned. Okay. The bedside test.
Urine dip.
Perfect. What else? You mentioned already while doing the investigation.
Bedside echo.
Perfect. For what?
Pulmonary hypertension.
Perfect. What else related to pulmonary hypertension you can do?
ECG.
Perfect. Yes. These are the possible bedside tests you can do for any patient, particularly our patient today. The image you mentioned already also in the investigation. You start with,
Chest X-ray.
and in advanced you can give option of
Yeah, CT scan of the chest.
high resolution CT. Yes. Perfect.
Okay.
Okay, the invasive test, what you can do as invasive.
Renal biopsy.
Yes, if you suspect
Um, are we still
lupus,
okay?
lupus, yeah, because also still lupus one of the possible association
Yes.
as autoimmune disease, right?
Yes.
Okay, yeah, fair enough. I know I missed some of the investigation. Everyone can think how much investigation we can offer to this patient. I agree, and I believe there is a lot of tests you can add here.
Yeah.
And the good thing you remember to offer fundoscopy just to rule out the papilledema. Why? Because this patient might have hypertensive encephalopathy,
Yeah.
and as a sequelae of hypertension, this patient might have papilledema. So it's perfect to offer it. However, it will not be specific or it will not add any positive finding in this scenario.
True.
Thank you, Dr. Isos, again. If you're ready, Dr. Marwa, you can start.
Yes.
Yeah, here you go.
Hello.
Hello.
My name is Dr. Marwa, one of the doctors in the clinic today. Can I confirm you are Mr. Alfredo and you are 50 years old?
Yes.
Mr. Alfredo, we are here today. Uh, uh, I'm here today to discussing your problem and examine you. Is that okay with you?
Yes.
Can you tell me how can I help you?
So, doctor, for the past 12 months, I've been having some double vision.
Yes. Can you describe it for me?
For instance, when I'm on my computer, I just realized that as I start reading, I start seeing double as I continue to use the computer.
In all in which direction? All directions or in certain direction? You see double
In all directions.
in all directions?
Yes.
Is it continuous
No.
all the day?
Well, if I rest, it gets better. But for instance, if I wake up, it's okay. But as the day goes, it gets worse.
Since it started from 1 year, is it increasing or decreasing?
It seems the same.
The same. It
Yeah.
started suddenly or gradual increasing?
Well, I just woke up one day and realized that that's how it is. So it was gradual, I would say.
Okay. Do you have anything other than this problem?
Well, I have
Do you,
I've noticed that I'm weaker. If that,
yes.
yeah,
Which part of your body you feel you are weaker?
I don't know. Maybe I
Your
think maybe
your arms, your legs.
maybe generally, but I notice when I walk in the train station, usually I can walk without getting weak from the train
Mm,
station. But now I notice that it's harder for me to like climb stairs.
difficult. But when you take rest, does this weakness improve or still the same?
Oh yes, it improves when I rest.
Okay. Do you have any other problem? You want to tell me?
No,
Okay. Do you have any headache?
no headache.
Uh, any abnormal sensation in your arms or legs or
No,
anywhere?
no,
Any fits?
no,
Sorry to ask you, any loss of control of your water work or bowel motion?
no,
So, do you have any long-lasting condition, or do you take medication for anything?
no,
Okay. Do you have uh, any change in your weight?
no,
Any joint pain?
no,
Any weather intolerance?
no,
Any lumps or bumps in anywhere in your body?
no,
And do you have any heart racing?
no,
Any shortness of breath?
no,
Any any cough?
no cough.
Any change in bowel motion?
No,
Any change in your water work?
no.
Did you have this problem before, or it's the first time?
So it started one month ago. Sorry, 12 months ago. This double vision,
Well,
but this
yes, before. Mm,
no before then no. But
okay,
this weakness I'm telling you about, it's been there as well, but it's gotten worse over the last 3 months. I can't walk, and sometimes when I tried fixing a shelf with my child, and I couldn't hold my hands up for a long time.
okay. I'm sorry for that, and we are going to help you as we can.
Thank you.
Did you fall? Do you have any falls while
No,
you're walking?
no,
Do you feel any dizziness?
no dizziness.
Uh, what you do? Is this symptoms affecting your daily life or your work?
Well, I'm a lawyer, so it is affecting my work because I can't type, I can't look at my computer, and I need it for work.
I'm so sorry for that, and we're trying to call it occupational workers to help you.
Thank you.
Okay. Are you drive?
Yes.
Oh, I highly appreciate. Recommended you to stop the. I want you to stop driving until we solve your condition, because driving while you're having this problem may affect your safety and other people's safety.
Okay. Thank you.
Do you welcome? Do you smoke? Do you
Never.
smoke?
No, never
Do
smoke.
you drink alcohol?
Occasionally the red wine when I'm at home.
Okay. Uh, you don't drink much alcohol,
No, no,
right?
no. Once
Okay.
in a while. Yeah.
I need to examine you, Mr. Alfredo.
Okay. What do you want to examine?
I general look any doses.
Yes, bilateral.
Bilateral ptosis.
Yes.
I will start by cranial nerve examination by visual acuity first.
Yeah, that's fine.
Fine.
Yeah.
Then I will examine visual field.
You can see some bilateral palsies, gaze palsies.
The eye movement for
The eye, yes,
eye movement.
yes, the eye movements.
Mm.
Yes.
Bilateral gaze palsy يعني vertical and horizontal gaze palsy.
Yes.
You mean?
Yes. So it's bilateral, more like extraocular muscle palsy. The patient is able to follow your gaze, but notice that it's becomes slower each time you try.
Okay. I will examine the facial nerve. I will ask the patient to elevate his eyebrows.
Yes, he can do that.
He can do.
Yes.
Ask the patient to tightly close his eyes.
He can do that.
Okay. I will examine now for proximal for the power in upper limb power.
Yes, there's proximal weakness in the upper limbs.
Okay, I will ask the patient to do the repeated abduction and abduction, and I will examine the power again.
Yes, there's fatigability present.
Okay, I will I will examine the neck for any thyroid and retrosternal percussion.
Okay, that's fine. Nothing.
I need to examine the lower limb for tone, power, reflexes, coordination.
Yes, so proximal weakness, like I said before, but reflexes are normal.
Okay. I need to see the gait.
Okay. Yes, so the patient walks, but just reports that he feels tired.
Okay. Any special gait?
No special gaits.
I will examine rhombic test.
It's fine.
Positive or negative?
And negative.
Positive, negative.
Yeah.
Okay. What's your concern, Mr. Alfredo?
I was trying to check my problems online, and it said something about motor neuron disease. Is it motor neuron disease, doctor?
I highly appreciate your concern and your words, Mr. Alfredo, but actually it is not motor neuron disease. It is a condition called myasthenia gravis, in which there is antibodies, in which your defense mechanism started to form what's called antibodies, such like substance attacking your muscles, and not muscles itself, but specific parts in your nervous in your body, and making your muscles weak, especially after effort. Is that clear to you, Mr. Alfredo?
Yes, doctor. So what?
Do you have any other? Okay. Continue.
What will you do for me, doctor?
I need to admit you, Mr. Alfredo, to do some to do some investigations and take blood samples, and take some tests, and assess your condition, giving you the medication. Also, I need to examine something again, something.
Okay.
I need to examine the chest for expansion and for breast sound.
Fine.
Just the expansion and breast sound.
Yeah, fine.
Okay. Also, Mr. Alfredo, we need to assess your respiratory, your breathing function, because this condition may affect your breathing.
Thank you. Okay.
Until that, I told you to stop driving, and if you need any uh, any help, you can ask us. Any question come to your mind, you can ask.
Okay. Thank you, doctor.
Look, this is a bit still time.
Still 3 minutes. What you want to
3
ask?
minutes.
Yeah.
Ask um, any family history of same problem.
No, doctor.
Any history of cancer in your family.
No.
Uh, mm,
Okay, in the examination, what else you want to examine?
examination. ال- هو بقى هو still الكارديوفاسكولار والجي اي تي
Mm-hmm. What
وال
particularly in GIT you want to examine? What particular part of GIT you want to examine? It's very important. Even as the history taking, not only the examine.
swallowing is swallowing. Any difficulty in swallowing?
Yeah, 2 minutes left now.
No
Any
difficult,
difficulty in swallowing?
no difficulty with swallowing.
Any choking?
No.
Any heart failure? No.
No.
Um, I will also ask the patient to count and note the tone of speech and the fatigability of voice.
Yes, so as the patient counts, the patient starts slurring the words and reports fatigue.
Nothing.
Yeah, now you remember what you have to examine in the myasthenia patient. Well, the last thing you want to nasal tone in the history. Yeah. Anyone told you that, or you notice your tone being like nasal one? Okay. 45 seconds. That's enough. We can start exam question now. Dr. Sosa, please.
Okay, so please present your findings.
My patient is Mr. Alfredo, 50 years old, complaining of diplopia. On examination, he has bilateral doses and thermoplegia in vertical and horizontal, and positive fatigability test in examination of the in the upper limb. Also, there is fatigability in counting. So my diagnosis is myasthenia gravis.
Okay. What are your differentials?
Other differential, the bilateral facial nerve palsy, lumbar Etienne syndrome, um, uh, supranuclear palsy,
Okay. So how
myotonic dystrophic.
okay. So how would you investigate and manage?
I need to do the basic investigations, including CBCs, CRB, ASR, kidney and liver function. Specific test, I need to do acetylcholine receptor antibodies, and if negative, I need to do mask antibody, muscle specific tyrosine kinase antibodies. Also, I need to do CT chest, looking for any thymoma, and I need to assess respiratory function and the force vital capacity, and I need to do ex- uh, respiratory function test. I need to admit the patient until assessment his condition and know is it myasthenic crisis or not. If myasthenic crisis, I will admit him. If no, will treat him as outpatient.
Okay. So this patient has bilateral ptosis, correct?
Yes.
So what simple bed test can you do with the ptosis that can then point you to myasthenia gravis?
Ice pack test will improve when we put the ice pack on eyelids will improve the ptosis.
Okay. So you talked about admitting the patient. Is there any surgical management in myasthenia gravis?
Yes, thymectomy will improve the symptoms of myasthenia gravis.
Okay, so you checked for retrosternal extension here. There was none. Supposing this patient is female and you did a CT to check and there was actually no thymoma, would you still offer thymectomy for the patient?
If the patient has generalized myasthenia gravis, thymectomy even without thymoma will improve the myasthenia gravis.
Yes. This patient had a concern for motor neuron disease. How would you differentiate this clinically from myasthenia gravis?
Motor neuron disease, myasthenia gravis here having diurnal variation and fatigability positive. In the motor neuron disease, it's continuous, not fatigability, not affecting by effort, and it is upper motor condition or mixed upper and lower motor, not muscle disease. But myasthenia is muscle disease.
Okay. Is there any investigation you forgot to mention?
Investigation for myasthenia?
Yes.
Heterophonium test, but it's not done now.
Okay, what else? You just mentioned it's a neuromuscular junction disease. So what other tests would you like to do for this patient aside the antibodies?
Other than antibodies?
Yes, you mentioned it's neuromuscular junction.
Yes.
So it's more about the muscles.
Yes, electromyography.
Fine.
Electromyography.
Final question. Say you found signs only in the eyes. Would you have been confident to diagnose this as ocular myasthenia?
What, again, the question?
So you found signs only in the eyes.
Only
If you found signs only in the eyes,
yes.
Would you have
Yes.
been confident enough to diagnose ocular myasthenia from just this examination?
From just examination, no.
Okay.
We need to continue the investigation.
Okay, thank you. I'm done. Thank you very much.
Thank you, Dr. Esosa. Well done, Dr. Marwa. Now we can hear the comment of Dr. Esosa, then I will comment.
Yes, thank you, Dr. Marwa. You did very well. I think you got the diagnosis from the very beginning. I just wanted to mention that the issues with swallowing, so it's not always a textbook case where you have all the symptoms happening, but it's good for you to ask. He had some positive symptoms. It was more of the diplopia and the proximal weakness. So that's fine. But I noticed you didn't, for social history, or even though you asked about smoking and alcohol, but you didn't ask about who he lives with. I think that is also
About what?
about who he lives with. Does he live alone? Does he
yes,
someone?
Yes. Right.
I think that is also
Yes.
that is important.
Yes.
Yes. Then I think my issue was more of the examination. I know, so I talked about ptosis, which you got immediately. Now, for the facial nerve examination, when you asked to close his eyes, I said he can close his eyes, but I think you should have attempted to open his eyes, especially with the fact that facial palsy one of your differentials. If you had attempted to open his eyes, then you would have known it was easy. It would have been very easy. Another thing is that for the facial palsy, you didn't ask him to smile. There's something called the myasthenia smile. So I would have given that
Yes.
to you. Okay. And then you realized late to ask about the nasal speech, the palatal weakness. So ask him to say offer for a gag reflex. Although it was absent in this patient, it would have still been good for you to check. Later at the end, you asked for the respiratory muscle function, which was also good. Truth be told, this patient didn't really have much. I know you asked questions and he just kept saying no, 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 because the question it was more straightforward, diplopia and problems with the general fatigue. Um, you didn't ask about allergies though? Did you ask about allergies?
Mm.
I remember. Yeah. So he has no allergies, but obviously you're going to start this patient on medications. You would like it to be important for you to know his allergies. Um, I think that's about it. You asked occupation. All in all, the questioning was good. And I think that's it. Thank you.
What about the differential?
So I
Differential.
have a different set of differentials here. My differential, number one, myasthenia gravis, number two, Lambert Eaton, which you put as your number three, which is okay. I also went with drug induced. So which is why I think you asked if I was on medications. Yeah? Did you ask?
I asked, yes, I asked. You
Yes.
said no
So
medication.
some medications can cause myasthenia gravis, for instance, penicillamine. So other differentials I put in just in case, especially with this proximal weakness and his diplopia, was Graves' disease or hyperthyroidism, although I know be more with females. So Graves' disease with Graves' ophthalmopathy can give you diplopia and um, proximal weakness, even though it's not fatigable. So those were the differentials I had in mind. Bilateral facial palsy, it won't explain his proximal weakness. And when you did the facial,
No.
say it again,
Mm.
your differential of bilateral facial palsy will not explain his proximal weakness. If it was
Yes.
diplopia, I think that would fly. But yeah, so those are the differentials I had though. But you got
Thank you.
the case, so that's fine.
I think myotonia dystrophica here is very important to rule out and to put it as a differential.
Yeah, you mentioned that as a
I yes.
different. That's my yeah.
Yeah, it's very important. Why? Because it's a young patient and he has diplopia, he has ptosis,
Mm-hmm.
myopathy. I think it's one of the most important differential you have to put in your mind.
Yeah.
Plus the methania, and I think also, however, he is a male.
Yeah.
Multiple sclerosis also is important to rule out here by asking for the weather or hot any exposure to hot weather can lead to these
Yeah.
symptoms.
Yeah.
So just to put in your mind, diplopia is important.
Mm-hmm.
Complain in the basis, and the presentation also can give you a clue what could be the reason of this diplopia and what differential you can put. Don't just give differential.
Mm.
I guess the facial palsy is difficult to be as a differential in this scenario. Why? Because accidentally to be bilateral facial palsy or third nerve palsy, I think you mean third nerve palsy, not facial palsy, right? Diplopia
I
means,
guess
yeah,
maybe wrong. Wrong.
yeah, not facial. Yeah, this is, it's
Yes.
third nerve palsy.
Yes.
So it's difficult to be bilaterally because the cause is either trauma or diabetes, and it will not be bilateral. Difficult to be bilateral. Anyway, so our case here, myasthenia gravis, as a differential or the case, then the myotonia dystrophica as a differential, multiple sclerosis the third differential. This for me. The question for multiple sclerosis is important to ask any weather change or any symptoms, or does it appear when you have hot weather? It's important to ask this question for of the phenomena. And myasthenia crisis, you have to ask about for the myasthenia gravis, what are the trigger? Because most of the myasthenic patients, they will have on and off, and it will be exaggerated with something like infection or antibodies. So it's
Mm.
important, as Dr. Isos said, the drug history or the medication. Any medication have taken later or recently. As also ask, you can say any previous attack, because myasthenia comes in on and off as a duration. I mean, as a or as an onset. Okay. Otherwise, I guess you finish early, Dr. Marwa, so you have something defective, either the history taking or the examination. You finish at minute 11, I guess, the examination and the history, and if you finish the history at minute 8. So you miss the history of family or the family history. That's why I ask you to ask what other question you want to ask
I ask about families.
by yourself, right? I didn't remind you. So what I remind you to do, the examination, right?
And the difficulty
Swallowing,
with swallowing. Yeah.
swallowing all
Yeah,
examination.
the GI question. Yeah, the
Mm.
GI question is important. This scenario shocking, as you mentioned.
Mhm.
The nasal speech, as Dr. Sosa said, and the counting is important to do. By the
Mm.
way, there is two fatigability tests you have to do. The first one in the eye, and the
Mm.
other one for the eye, of course, for the ocular one, the ocular type of myasthenia. And for the systemic, you have to ask for the proximal myopathy. So you'll ask the patient to move one limb, one arm. You know the
Mm.
movement, Dr. Marwa, right?
Yes, yes.
The same movement
Abduction or
of
adduction.
exactly, but keep one arm fixed, and the other one will be
Mm.
adducted,
Mm.
then abduction. And after 20 counts, you can compare or do the adduction in comparison. So you'll find one arm is weaker than the other. This is for what's called fatigability test for the proximal myopathy. The other one for the counting, ask the patient to look up and count from 1 to 20. The
Yeah.
eyes will be weak, and he will have the ptosis, and the count itself, the tone will be lower. So by this, you will discover two things: the weakness in the eye and the eyelids,
Mm.
and the count itself will be weaker for the bulbar, I mean. This is related to the myasthenia itself. The myotonia dystrophica, you can ask about the association like diabetes or the cataract or the family history. Of course, you will find positive family history. Okay, these are the three differential, and you should roll out all of them. But the case here is straightforward for myasthenia gravis. The most important, as you did at the end, to measure for the forced vital capacity, what number you can give to admit this patient, Dr. Maro?
Below 20 milli
Perfect. So
per
below
kg.
20 ml per kg, this patient should be monitored in ICU. For the previous case, I forgot to mention the indication of admission, Dr. Isosa. You
Okay.
mentioned to her I should admit you for the
Yeah.
previous case, the hypertension or the headache related to hypertension.
Yes.
Why you should admit the patient?
Oh, because it's renal crisis.
Perfect. So it's called, what's called this thing? What do you call this?
This scleroderma renal crisis.
Scleroderma crisis. In another way, in the hypertension definition, what you
Or
call this?
hypertensive crisis. Emergency.
Hypertensive, yeah, or another term, another medical term.
Oh, I'm not sure.
Emergency. Hypertension.
Hypertensive urgency or emergency.
Emergency. Oh, yeah. Emergency.
Emergency. Whenever you have end organ damage, you can call it hypertensive emergency.
Emergency. Yeah.
Yeah, and you will give the patient IV medication. But in the urgency, hypertensive urgency, you will give the patient oral medication, oral antihypertensive. But you will not have end organ damage. Okay, just high reading, more than 180. Back to our case here, myasthenia gravis. You have to rule out thyroid. Dr. Marwa already rolled out any thyroid because it might be associated with thyroid disease. You mentioned retrosternal extension, Dr. Marwa. It's not retrosternal extension. You are doing retrosternal dullness for
Percussion.
thymoma.
Yes, yes.
You, you said for thyroid or for extension. No, it's not
Yes,
retrosternal. The
I
thyroid.
mean percussion. Still
Yeah,
percussion.
percussion dullness for thymoma.
Yes.
Otherwise, the investigation, the antibodies, the general investigation, the inflammatory markers, the um, other investigation, you mentioned the image, yeah, CT chest to rule out thymoma, and the antibodies you already mentioned, the management plan, I think also you cover, but you didn't counsel about medication. This patient should be seeking medical advice anytime he will have infection. Why? What do you think?
Because the infection exacerbated myasthenia. Also should
Only the
tell him
infection or
infection والمedication
yes,
will
exactly.
benefit.
Yeah, so the medication, the antibodies itself can lead to the myasthenia crisis, or the infection itself can lead to the myasthenia crisis. So this patient should be counseled about the disease, the triggers for the disease, not only the antibodies. There is a lot of medication can lead to myasthenia crisis, right?
Yes.
Okay, what else we can mention in this topic? Anything missed, Dr. Marwa, Dr. Isosa? Anything to be
Maybe
added? Yeah.
الأوتوimmune association ممكن may
Autoimmune thyroid.
ask about
Graves. So two graves. You have two graves, myasthenia gravis and thyroid,
any
right?
autoimmune maybe Addison also
Yes, there are some auto.
for Addison any autoimmune
Yes, I think here it's written.
may be associated.
Yes, diabetes mellitus, rheumatoid arthritis, thyrotoxicosis, SLE, and thymomas. So there are also associations. But you asked me in the past medical history. So
Mm.
Yeah, but the most important is the thyroid disease.
Yes.
Okay. Okay. Let's open the discussion. Any missed point, Dr. Isosa, you want to add? Any suggestion?
no, I don't think I have any. Oh, I
Yeah.
just wanted to confirm though. I know that so the case was myasthenia gravis, so I think the focus was more on neurology, but I still felt maybe you should have also done abdominal exam, like the other examinations, just to make sure that your examination um is full. But I don't know if that's the case, because I know that this is more of neurology, but you didn't do abdominal examination. So
Why abdominal examination you want to do here?
So yeah, so there's no need, but I just thought that when you examine the patient, you should just examine fully. Or is there
Yeah, I believe you have to do the full neurological examination, this scenario, plus some cranial nerve examination and thyroid examination,
okay, so you don't
plus
need to do all.
plus eye examination. No, I don't think anything will be important in the abdomen to examine.
Okay. Yeah. So you don't get a mark for, oh, she did an abdominal, she did a CVS.
No, 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 no. I believe if you do the neurological examination, it's much important than other examination. I mean, tone, power, reflex, coordination, and sensation. You have to also to examine the sensation here, and don't forget the gait, as Dr. Marwa did.
Yeah.
The proximal myopathy, fatigability, counting, all these are important to do in this case. But for the abdomen examination, I don't think it's important to do in this scenario. Lymph node examination as well important to do in the neck. Don't forget it, Dr. Marwa. Okay.
Okay.
Any miss point, Dr. Isusa, you want to add?
No, I can't think of anyone. Thank you.
Yeah, thank you too. Dr. Marwa, any question? Yeah, the
No,
chest expansion is important. Sorry, Dr. Marwa?
I said no, no, no questions.
Okay,
You asked
okay,
me.
okay. I will read the comment quickly. I think There is precious comment, of course, because Dr. Aisha already commented, Dr. Samah. Okay, we'll start with Dr. Samah. Aminoglycoside, perfect. Beta blocker, yes, of course. You have to remember at least the most important antibodies or the most dangerous antibiotics, sorry, aminoglycoside. But macrolide also is important to avoid because also can lead to myasthenic crisis, as well as tetracycline. Beta blocker, yes, I think also phenytoin, some anti-epileptic drugs, inhalers or narcotics, anesthetic. It's important also to remember. Skin rash, pemphigus vulgaris as association, yes, I agree. Some cases comes with the skin rash, and you will find in the history myasthenia gravis, but never they will bring both together. It's difficult to do both examination. Pemphigus vulgaris, yes. Okay, Dr. Aisha commented chest, I think important. As a, yes, you mean for the palpation, for the expansion, right? So it's important to examine for the palpation as for the expansion of the lung. If there is limitation, you may say this is a myasthenia crisis patient. But instead, you can offer respiratory function test or pulmonary function test. Why? To do forced vital capacity to check for less than 20 ml per kg. This patient might have, or he's mostly or probably he is in myasthenia crisis. More important to examine lower limb examination. Yeah, either upper or lower. By the way, you can do fatigability test either in the arm by the count and the adduction frequently, or you can ask the patient to stand and sit without support frequently. Or you can ask the patient while sitting to raise his thigh up frequently, one side. By the way, you have to do the fatigability test unilateral examination. So don't ask the patient to do both together. How you will know if there is fatigability? So you have to compare between both legs or both thighs. Okay. One of the important question in the history to mention the timing. Dr. Isosa was volunteer to say, yeah, I feel difficult, and when I take rest, I feel fine or better. But the most important, show the examiner while asking this question, do you think is it related to the evening time? So whenever you are at the evening, you feel more tired. Yes, I have. So this is conclusive for my senior patients. Okay, Dr. Aisha again, I mean chest finish after my senior. Yes, of course. The neurological much important than the chest. But again, the chest might be examined. It's important to roll out involvement of the chest at the end of the day. Oh, yes, exactly. So at the evening or at the end of the day, the timing is important to mention, to specify it. It's very important to say this. Thank you, Dr. Samah. Any other question or suggestion, added point, any missed point, please? We are here to make the topic perfect. I'm not perfect, even the candidate not perfect, anyone not perfect, but we are trying to make it as complementary to each other. So anyone has comment, please add it. Any missed point, please add it. The investigation, Dr. Marwa, you mentioned single fiber. Okay, single muscle fiber electromyography. This is the conclusive or diagnostic test. Don't forget to mention. Nerve conduction study, yes, you have to mention. The antibodies, you mentioned, anti-mask. What else we want to add? Anything missed, please? So seems satisfied for all. Dr. Isosa, Dr. Marwa, any comment before ending the session?
No comment. Thank you.
Thank you too. Special
Thank
thanks
you,
to
doctor.
Dr. Marwa. Yeah, I think two topics are very important and very high yield topic in the exam, in the PACES exam. Systemic sclerosis with complication, whatever the complication, either high or difficult swallowing, dysphagia, or hypertensive with headache, or even short of breath, cough. So it might be present with any of these, and you might have a complaint with any of these. The other topic is important diplopia. Again, don't forget the most three important cause of diplopia in the exam. The first one, multiple sclerosis. The second one, myotonia dystrophica and myasthenia gravis. Other causes comes, but not like this. I mean, third nerve palsy,
But here,
or
Dr.
even
Bassett, the age of the patient, 50, I
yeah,
think it's not sensible to say myotonia
myotonia
or
dystrophy.
on multiple sclerosis. So it's better to mention first the lumbar eaton and drug-induced, I think,
Mhm. Okay,
because it's
makes sense.
according to the case. Yes, I know this is the most common cause of diplopia, but
Mhm.
for the case, it is clearly myasthenia. So it is better to mention the other causes of myasthenia, like the other
Number
causes of
18.
different time of weakness, yeah.
Mhm.
Like to be ocular, only ocular myasthenia, or to be lumbar eaton, to have cancer, and this is induced
Okay,
antibodies,
yeah,
yeah.
it makes sense. But again, it's as you said, it's the importance topic we mentioned
Mhm.
already, myotonia dystrophica, but not
We can,
usually.
if the examiner ask about other causes of diplopia, so we can mention the others,
Hmm.
like all you said. But if differential of this case, I think
As a
to
age, you
mention
mean?
the other, yes,
Yeah,
because it
for
is
the age.
50,
Yeah, yeah.
yeah, and it
Okay.
is recently started. So, and if multiple sclerosis will come and go like attacks,
Mm-hmm.
so it is better to, according to the case, to mention the differential. Other than this, if he mentioned differential of what? Of symptoms, special symptoms, you can enumerate the commonest of these
Oh,
symptoms.
okay. Thank you, Dr. Aisha. Again, yeah, you have to put differential make sense related to the age. I agree with this, but again, the most important three topics as cause of diplopia, what I mentioned already. But for the age, you can say against this age or the against this differential, it comes in early or young patient. However, myotonia dystrophica, it's not necessary to be in young patient, by the way, Dr. Aisha. They might live longer. Yeah, they might have heart or cardiac disease and
Yes,
they
I
might
know,
die.
but the history will be
Yeah.
different, very different.
Yeah, but
Uh,
still there is ptosis, there is proximal myopathy or difficulty distal or proximal according to the type,
but
but
not for
similar to
months or
myasthenia.
days. It will be like years or
Yeah, it takes,
something like that.
yeah,
Yes.
and progressive disease. It's not on and off, it's progressive one.
Yes, and at this age, he will be like wheelchair, not,
Wheelchair, yes,
yeah.
wheelchair bound, yes, you're right. Okay, again, you can say against that and specify or mention whatever you want. Thank you for the comment, Dr. Aisha. Any other comment you want to add, Dr. Aisha?
الدبلوبيا اللي هي due
No,
to
thank you.
multiple sclerosis دبلوبيا
Mhm.
when
Painful.
it
Mhm.
painful
Third
like
policy,
yes
or sixth nerve policy.
Mm.
optic neuritis due to optic neuritis
Yeah, yeah.
No, optic neuritis will call the decreased vision and the painful eyes like that.
yes it is optic
But
neuritis
diplopia, it is because third policy or sixth policy or any cranial, other cranial policy.
systemic when systemic sclerosis associated with diplopia
Multiple, you mean multiple. Um, associated with
multiple
diplopia when
sclerosis
affect the third or the sixth or the seventh nerve.
The,
This is nerves
the
of the
sixth,
eyes.
sixth nerve is not
Fourth,
affected.
fourth,
Yeah,
three, four, six. Yeah,
it's
any
not
one of
commonly
this.
affected. It's not commonly affected, but
Yes, the three, but the six, yes, the commonest. I think
the
the
the,
commonest.
the commonest is
Four,
two,
four,
the
six.
second optic.
Yes, but it's not causing diplopia. It's causing decreased vision or loss of vision, painful
Yeah.
eye. Yes.
Okay. Again, for the important also the differential, as Dr. Aisha mentioned, we can add the intracranial hypertension, idiopathic intracranial hypertension. It might be also associated with sixth nerve palsy.
Yes, all the increased endocrine, even if tumor in the brain, even any,
Yeah.
will cause also six palsy and diplopia.
Yeah, it's as Dr. Marwa also mentioned, it's not commonly associated with multiple sclerosis, but you have to rule out multiple sclerosis, particularly if you have female patient. It's not commonly association, the diplopia, but the optic neuritis is the most important presentation. Clear now?
Sorry, can I just comment though?
Yeah,
Multiple sclerosis is associated with INO, internuclear ophthalmoplegia. So
exactly.
just wanted to mention that because these patients will have diplopia.
Diplopia, yes.
So
Yeah,
just wanted to mention.
this is the way, yeah, why this multiple sclerosis patient will have diplopia because of the medial longitudinal
Yes, this is
fasciculus, yeah.
like conscious, like um, the
Yeah,
eyes
so
not follow the other, but not
exactly,
through
both eyes.
diplopia. Yes, yes.
Yes, both eyes will have the
No,
difficult
no
movement.
nerve palsy, but this is a medial
Yeah,
longitudinal
it's not
stress
six.
of,
Six and fourth is not injured in the
yes,
multiple sclerosis.
yes,
The,
yes.
the injured nerve in multiple sclerosis, either the second optic nerve or, as Dr. Isusa said,
Yes,
the
thank you for remembering.
yeah,
Yes, this is the most common site for
exactly, yes.
affecting is multiple sclerosis. Yes,
But still one of the differential multiple sclerosis,
yes, MS, yes.
and particularly the female patient. Of course, you have to add the of the phenomena as a clue, but put it in your mind to put it in the differential outside. Whenever you are outside, you have diplopia. Put those three differential in your paper and try to get the clue for each symptom or for each disease to roll out one by one and follow your systemic review till you reach the diagnosis. Thank you, Dr. Isosa and Dr. Marwa again for nice session. It was very informative one of the important high-yield topics, the diplopia, and the other case was hypertension associated with headache. Thank you everyone for the attendance. Tomorrow we'll skip and we'll have session most probably after tomorrow. If I can arrange tomorrow session, I will send you the announcement. However, I will try to make 3 sessions in this week like the previous week. Okay, anyone want to practice? Let me know. Send me a direct message through WhatsApp. Thank you everyone. See you inshallah next session. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.